All right, so I'm going to talk about how not to contribute to the opioid crisis. I have no disclosures. So I think the first thing to do is to make a statement of the problem. So do we have a problem? So unfortunately we do. While there have been different points in U.S. history where there have been opioid epidemics, the current epidemic is the worst and was actually named a public health emergency in 2017. So this started kind of in three waves. So back in kind of the early 2000s, it was the entry of prescription opioids onto the streets. This transitioned into a higher use of heroin as those drugs became less prevalent. And then finally, the more recent increase in synthetic opioids that are available, leading to increasing overdose rates. So unfortunately, there are only two access points to getting into this problem, drug dealers and us as healthcare providers. So what's different about this epidemic as compared to ones in the past is that previously those patients being treated for heroin addiction often started with heroin. So it was heroin addicts now being treated for heroin addicts. Now more recently, we're seeing patients being treated for heroin addiction that actually started with prescription opioids. So we as providers are the ones that are providing them with a gateway. And in this paper from 2014, 75% of people in treatment facilities for heroin addiction had started with prescription pain medicine. So how did we as physicians become part of the problem? The first step was that in the late 1980s and early 1990s, there was this emphasis on pain as the fifth vital sign and having patients have zero pain while they're admitted to the hospital and postoperatively. This was encouraged by the Joint Commission, the VA, and the American Pain Society. Next, pharmaceutical companies like Purdue Pharma, which has been in the news a lot recently, presented weak data saying that their new drugs like OxyContin were not addictive and were safe for patients to take on a regular basis. They also aggressively marketed to physicians that these were safe and encouraged them to use them in patients to get patients' pain to that zero level. And finally, I think there was this unclear set of expectations between providers and patients as to how their pain would be controlled, what they would experience after surgery, and the best way to manage their pain postoperatively. So I think the first problem is that we as providers really have no idea how much pain patients experience after surgery. So this was a study performed at Dartmouth that looked at common general surgery procedures. And what I'll highlight here is just the significant variation in the amount of opioids that were prescribed to these patients postoperatively. In the middle there is the laparoscopic cholecystectomy. Some patients got zero narcotics after surgery, and some patients got 100 pills of some form of narcotic prescribed after surgery. So we really don't have a good bearing on what patients are experiencing. And then in this group, only 2% of patients really required any sort of a refill for pain medication, suggesting that we're certainly erring on the side of overprescribing rather than underprescribing and then refilling as needed. And finally, if you looked at how many of those pills patients actually took, this was done via phone interview, so may have some issues, but on average for all of these procedures, 70% of the tablets that were prescribed were not actually taken by the patients in the postoperative period. If we look at kind of colorectal in general, this is a paper also out of Dartmouth that looked at anorectal operations specifically. Similar problem here. We have no idea how much pain we're causing after we do these anorectal procedures and have a very wide range of prescribing tendencies after common anorectal procedures. And again, the number of pain medications that are left over after these surgeries is 83.5% not taken by patients. Again, this is patient reported, but is definitely a high percentage of those being prescribed. This is a graph out of the CDC. So in addition to us not really knowing how much pain patients have, then providing this sort of overabundance of opioids to be abused or used improperly. This study out of the CDC showed the likelihood of patients who are opioid naive of still being on opioids long term, depending on how long of a prescription they were given or how long they were told to take opioids. At about the 5 to 7 day mark, you see a significant increase in the probability that patients will still be on narcotics 1 year and 3 years after this first prescription. And again, this is in naive patients, so not patients with chronic pain already on opioids. If we look at surgical patients specifically, this is a paper published out of Michigan. It looked at common general surgery procedures, and we as colorectal surgeons, colectomy is one of the highest rates of having patients on narcotics long term, and this is at 90 days and then a year out from surgery, and this ranges from 6 to 10% of patients that were opioid naive. They also highlighted some risk factors of patients for remaining on opioids long term. They saw that younger age, tobacco abuse, higher comorbidity index, anxiety, chronic pain at baseline, and then previous opioid prescriptions, as well as an initial prescription of greater than 300 morphine equivalents, were all associated with patients being on opioids long-term after a surgical procedure. So what can we do to fix this problem? Well, part of it is sort of being mandated on us. There are now federal and state regulations in a lot of locations on how we can prescribe these medications. Prescription monitoring programs have been started, so some of that actually helps us because we can get an idea of whether or not our patients have been on these medications previously, or doctor shopping and getting multiple prescriptions from multiple providers. A lot of this lies in patient education, so setting reasonable expectations and setting up a pain control plan for our patients postoperatively, and then us as physicians kind of taking the lead on how to decrease the problem. So we'll start with sort of federal and state legislation. Specific to Minnesota, there have been a lot of changes more recently. They define pain control into 3 phases: the acute phase, which is up to 7 days after a procedure; the post-acute phase, which extends to 45 days; and then chronic, which is beyond the 45 days. In their general guidelines, they don't give kind of specific prescribing medications, but they encourage multimodal anesthesia. They encourage the documentation of pain scores and also of objective findings, not just the subjective description of patients. Identifying risk factors in patients that make them more susceptible to abuse. Now, it's soon going to be mandated that you actually check the prescription monitoring program before you prescribe opioids to see if they have gotten a recent prescription, or if you're refilling it, if they've asked their primary for another prescription as well. And then they also suggest limiting prescriptions to 100 to 200 morphine equivalents in that acute period and the post-acute period. So what that looks like for kind of common medications that we prescribe: so Vicodin would be 20 to 40 tablets postoperatively. Oxycodone is in 12 to 24 tablets, and then tramadol is in the 20 to 40 tablet range. And then this is just a map of all of the states that actually share information with Minnesota. What's helpful about this is surrounding states for our patients that come across borders. We can actually see if they're filling them in Wisconsin or the Dakotas and then coming to us also to get them filled. Not every state participates, but more states are starting to communicate with each other to help us make the most informed decisions. The next thing is patient education. So this is sort of a generic recommendation from the American Pain Society, but I think what's important about it is setting up expectations for our patients of how much pain they're going to have, and then highlighting some of the non-narcotic interventions they can use, including NSAIDs, Tylenol, also heat, ice, different things that can decrease their pain, and emphasizing that the narcotics should be taken as a last resort for severe pain. The other thing that we can significantly improve on is what patients do when they have 70% of their narcotic prescriptions sitting in their cabinet. These are the DEA recommendations for how to properly dispose of narcotics. Long story short is either mix them with things that are unpalatable so that someone can't take them, or return them to somewhere that will properly dispose of them. In their most recent studies, they've shown that 74% of patients postoperatively still have leftover opioids, and only 9% of them actually dispose of them in a responsible manner. So this is a newer website that's now available that you can send patients to. This is for our current zip code, and then you can find places within 10 miles that will take your leftover opioids and dispose of them properly. This is getting into kind of what surgeons specifically have done to help overcome this problem. So this is a program that was developed by 2 surgeons, an orthopedic surgeon and an OMFS surgeon in Ohio, which is kind of the epicenter of the opioid epidemic. They developed this pain pack, which is called the Optimal Recovery Plan, and basically emphasizes the use of Tylenol and ibuprofen in a scheduled fashion, and then only taking opioids as needed. In the year that they instituted this program, they saw a 75% reduction in the amount of opioids that they were prescribing to patients. Now, some of that is certainly their practice, but the other is the not needing refills of medications also. And this is just a copy of what their pain pack protocol is. So you can see it has writing down the times of when patients are taking the Tylenol, how long they should wait between that and taking Motrin, and how they should space this out throughout the day, and encourages them to do that. It also highlights all of the side effects of oxycodone. It sort of goes a little overboard, I think, where it calls oxycodone heroin in a pill, But in general, it's having patients at least record that they're taking these non-narcotic medicines, having them take them around the clock, and then having them track how often they're actually taking the opioids. In some ways to give us more information about their pain control, but also for them to get an idea of what they're using. So this paper is out of Cincinnati. Ian Paquette alluded to this earlier. They were mainly looking at length of stay, but what's highlighted in this is with their ERAS protocol and their multimodal pain regimen, they were able to decrease the amount of narcotics taken in the hospital by patients from 720 milliequivalents of morphine equivalents to 211 morphine equivalents. So even just in the hospital setting where patients have a lot more access to this, we can decrease it just by introducing and having a scheduled fashion of non-narcotic pain medicine. And this last review here sort of tried to put everything together and how we sort of can approach this with patients and put all this information together. So they developed this RIGHT strategy. So the first one I think is what is kind of new for this, which is the risk for an adverse event. So the table on the right there is the Webster opioid risk calculator, which is an easy calculator that you can use to determine whether your patient is at low, moderate, or high risk for opioid abuse. I don't know that that necessarily should change how you prescribe them narcotics, but you may be more aware when they're calling in for more and more refills, or making requests of other things, and also encouraging the multimodal pain control in these patients. So family history or personal history of substance abuse, younger age, history of sexual abuse, psychological disorders, and then there are different scoring for both male and female gender that can kind of give you a rough idea of patients that may be at higher risk of abusing substances. And then the other things we've kind of talked to, the insight into pain, so talking to your patients about the expected pain and ways that they can manage it without narcotics, going over the plan for that, minimizing narcotics use, educating on them on how to properly dispose of narcotics, and then identifying trouble behavior, so patients that are calling for multiple prescriptions, patients that had a refill from their primary a few days before they see you in the office, things like that. And then finally, this is from the Michigan State website. So what they did is they took common general surgery procedures and then looked at opioid-naive patients and how many narcotics they were taking. So on average for each of these procedures, it's about 80 to 120 patients over anywhere from 15 to 25 hospitals. The graph here is specifically for a laparoscopic colectomy. So what they saw is that after a laparoscopic colectomy, when patients went home, 50% of them took 3 or less pain tablets when they went home. 75% were 13 tablets or less. And then you can see the range goes above to up to 30. So their recommended amount was in the 0 to 15 range, so just above that 75th percentile for both laparoscopic and open colectomy based on their data, which is relatively small numbers, but is at least somewhere to start. And then the other procedures that they had that are relevant to our specialty, so ostomy opening, ostomy creations, closures, also the 0 to 15, and then for some reason open small bowel resections were 0 to 20 range. Unfortunately, they do not have any anorectal procedures, which is, I think, the area where we probably struggle the most with trying to judge what patient's pain is, but hopefully that's up and coming. So in summary, we as healthcare providers have certainly contributed to the opioid epidemic. I think by focusing on multimodal pain control, and setting reasonable expectations for our patients and giving them different methods in order to control their pain that are not just opioid pain medications is key to solving the problem. Education on proper disposal is probably the next key to the problem. And then also continuing research so we as providers have a better idea on where to start with giving our patients pain medications. At least in Minnesota, it is getting a little bit easier because we can now electronically prescribe narcotics, which helps with monitoring them, but also helps if a patient needs a refill. It's not coming into the office to pick up a paper prescription. They just need to go to their local pharmacy. So I think that can help as well, erring on the side of lower prescriptions and then refilling as needed rather than the other way around. So that's all I have.